Hello guys, welcome everyone. So how are you doing? I'm Dr. Patil, and if you're connecting me with me for the first time on this Master ECG series, then welcome all of you to the Physics Mala MedEd channel. And here we are doing the Master ECG series. What is this Master ECG series? A very slow, stepwise approach to learning the ECGs from ground up. कुछ भी नहीं जानते हो वहां से स्टार्ट करके वी आर ट्राइंग टू बी द मास्टर्स ऑफ ECG. तो हमने ऑलरेडी कुछ सेशंस कर दिया है टू एड्रेस द बेसिक्स एंड स्टार्टिंग फ्रॉम देयर वी हैव रीच नाउ द QRS कॉम्प्लेक्सेस. जो आज का सेशन है, टुडे सेशन इज ओनली फॉर 10 to 12 minutes addressing some key points about QRS complexes and understanding their utilization when it comes to clinical diagnosis or how we can use QRS complexes in making diagnosis of certain disorders. Okay. तो ये QRS complexes क्या represent करते हैं? QRS complexes represent the ventricular depolarization, right? QRS complexes are the waves of ventricular depolarization. They indicate ventricular depolarization. So if I'm suspecting some pathology of the ventricles and if I want to look into the ECG for it, QRS complexes are my window to the ventricles, right? They indicate ventricular depolarization. We already know that when we see an ECG, on the x-axis we have time, and on the y-axis, height-wise, we have the voltage or amplitude. So these QRS complexes also have time on the ECG. They have the voltage on the ECG. So QRS complexes, we'll try to understand what is the normal QRS duration and normal QRS voltage. Normal QRS complexes. The duration है जो normal QRS का, the normal QRS duration is around 100 milliseconds, not more than 120 milliseconds. So the duration is usually 80 to 100 milliseconds, and the point to note here, it does not exceed 120 milliseconds in normal physiological state. अगर ये 120 milliseconds से ज़्यादा है तो वो abnormal है, right? Now this is my atria, these are my ventricles. This is where I have the SA node. This is where I have the AV node. So impulse comes from SA node to AV node. AV node picks that up, does the delay that it should do, and then passes down the impulse to his bundle to his bundle branches, and from his bundle branches to the ventricles through what we call as Purkinje fibers. So QRS complexes talks to me about the time taken for the beginning of depolarization of the His bundle to completion of the depolarization of the ventricles. This is the wave of depolarization of ventricles. So if I am taking more than usual time, what will happen to the QRS duration? It will become wide. If I am taking less than usual time, the QRS complex can become short. Okay. So we'll go back to the QRS duration in a bit. Now what is the normal QRS voltage? जो QRS का normal voltage होता है वो क्या होता है? Okay, I'll take you through some ECGs and just look at this and tell me what is the normal QRS voltage. Is this having normal QRS voltage? Voltage means height, right? We know that one small square on this is equal to 0.1 millivolt. One small square is equal to 0.1 millivolt. Okay, so in that case, ये normal है या नहीं है? Okay, well, रिमेंबर नॉर्मल वोल्टेज में ECG का QRS का डिफाइन आसानी से नहीं कर सकता हूँ. I cannot define it easily. Why? Because when I look from one lead to other lead, the QRS voltage changes. Remember, we have already done the lead placements. So we are placing the leads in different locations. So the amount of voltage they are able to capture is going to be different. So what is important here? I have to concentrate on the chest leads or precordial leads. And in a normal ECG, when I look at the chest leads, the prominent wave that I get in V1 is S wave, and as I move forward from V1 to V2, V2 to V3, and I move forward, the S goes on becoming shorter and R goes on becoming taller. R goes on becoming taller. So when I see V1, the R is barely recognizable, S is the predominant wave. But as I go forward, R is becoming more and more taller, S is barely recognizable. So by the time I reach V6, S is barely recognizable. So this is what we call as the progression of R waves. तो अगर मैं R wave का या S wave का voltage निकालता जाऊंगा, so it will be different in different leads. So we cannot define normal for individual leads. So what do? We just know a rough rule that the QRS voltage or amplitude is, it should be, amplitude of the QRS should be more than 1 millivolt in chest leads, and it should be less than 1 millivolt, I mean it should be more than 1 millivolt in chest leads, and it should be more than 0.5 millivolts in limb leads. Now what do I mean by chest leads? Chest leads are my V1 to V6, and the limb leads are 1, 2, 3, and augmented limb leads, that is AVR, AVF, and AVL. So in all these leads, the QRS complexes, the height of QRS complex should be at least 0.5 millivolts. Remember, one small square is equal to 0.1 millivolts, means 5 small boxes. And in the chest leads, 10 small boxes or 2 large boxes. If it is less than this, we will say low QRS amplitude. If it is more than this, we will call it as high QRS amplitude. Okay. In terms of duration, anything that is taking more than 120 milliseconds. 1 millisecond is one small square is 40 milliseconds. So if QRS is taking more than 3 small boxes, it is abnormal, right? So first we will address wide QRS complexes. In what conditions I get wide QRS complexes? So wide QRS complexes, number one, I can get when time taken for the ventricle to get depolarized is increased. When it can get increased, I'll give you an example. If I have a bundle branch block, left bundle branch is blocked. So then how will I depolarize the left ventricle? Right ventricle will get the electrical impulse from the regular pathway. It will get depolarized. What about left? The wave that sweeps across the right ventricle to cause its depolarization will come to the left ventricle to cause its depolarization. But in that case, pehla kaun sa? Which chamber is getting depolarized first? The right ventricle. That is getting depolarized. That is depolarizing the left ventricle later. So to complete the depolarization, now I'm going to take more time. So in that case, I can have QRS complex become wide, right? So when do I call it as wide? When the QRS duration is more than 120 millisecond, which is nothing but QRS more than 3 small squares. 3 small squares. And typically this can be seen in RBBB or left bundle branch block. Second, we can also get wide QRS complexes when it is induced by drugs. We can get wide QRS complexes in ventricular arrhythmias. You might have come across ventricular tachycardia and ventricular fibrillation. In those cases, we can get wide QRS complexes. And then we have already discussed one condition where we had wide QRS complexes, where the depolarization of the ventricle started early, and because of that the QRS became wide. What am I talking about? Yes, WPW syndrome. So in all these conditions, the QRS complexes can become wide. So from the perspective of exam, detection of RBBB and LBBB is important. Detection of ventricular arrhythmias is important. Both of them I will discuss in a separate session. WPW syndrome, we have already discussed it. So now I will keep the wideness of the QRS complex aside because both of them are going to be discussed later. We will concentrate on the amplitude. So remember, if I have any increase in the muscle bulk of a ventricle, if a ventricle becomes more muscular, you should tell me to contract that. Do I need the regular amount of voltage or electrical impulse, or I need more? Of course I need more, right? See, now look at this ECG. This is the amount of voltage I had to give to contract this left ventricle or this patient's ventricle. Now if it becomes more muscular, I need more voltage to contract it. So whenever we have hypertrophy of right ventricle or left ventricle, the amplitude increases. The amplitude increases. So talking about the QRS amplitude, the QRS amplitude, we have already defined what is the normal QRS amplitude, right? Normally I cannot define a standard value for all leads. What I know is chest leads, all of them should have more than 1 millivolt. Limb lead should have more than 0.5 millivolts. If it is less than that, it is abnormal, right? In that case, we call it as low QRS amplitude. Low QRS amplitude. What does it indicate? That means in chest leads, the QRS is less than 1 millivolt. 1 millivolt means less than 10 small squares, and in limb leads it is less than 0.5 millivolts. In what conditions I can get it? Causes for this low QRS amplitude. Remember, around this heart, this is my heart, I am placing electrodes here and recording its electrical impulse. And if I fill this with fluid, what will happen to the voltage that is reaching my electrodes? It will come down. So if I have pericardial effusion, and for that matter even cardiac tamponade, the voltage will come down, right? Another condition where I can have low QRS voltage is hypothyroidism. So I want you to remember two conditions for low QRS voltage. The first one is hypothyroidism, which is common way more common than pericardial effusion. But if there is effusion, that will also filter down the voltages, so voltages reaching the electrodes will come down. So pericardial effusion or cardiac tamponade will have low voltage complexes. So with respect to the low amplitude, this is what we should know. If chest leads, they appear to be less than 1 millivolt, and limb leads, they appear to be less than 0.5 millivolts, we call it as low voltages, and I would suspect hypothyroidism or pericardial effusion or cardiac tamponade. Now the high QRS amplitude. High amplitude, I should mainly suspect RVH or LVH. High QRS amplitude, I should suspect RVH or LVH, because amplitude or voltage उतना ज़्यादा क्यों होगा? Because ventricular muscle mass is more, so to contract that I have to deliver more voltage. That's why it is requiring higher voltage. Okay, so now we will learn how to recognize left ventricular hypertrophy on the ECG. I think I've already told you that I cannot define the normal QRS voltage for a single lead, because from V1 to V6, S will be prominent in V1. As it goes down, S goes decreasing, R goes increasing, right? So when I have to come out with the criteria, I have to take into account V1 and V5 or V6. So keeping that in mind, we have a formula for recognition of LVH, which is called as Sokolov-Lyon criteria, which is also called as, it is one of the voltage criteria, because for recognition of LVH, what are we relying on? Relying on the voltages of QRS complexes. So according to this criteria, the S wave, what is the most prominent wave in V1? Usually S, right? So S in V1, we will calculate its voltage or amplitude, plus we will look at the R in V5 or V6, V5 or V6. We are seeing the voltage of both. If it is more than, if this sum is more than or equal to 35 small squares, or in terms of voltage, that is more than or equal to 0.35 millivolts, it is suggestive of left ventricular hypertrophy. What have we called this criteria as? Sokolov-Lyon criteria, right? So we will go through some ECG and see if we can identify whether that patient has got the left ventricular hypertrophy or not. Now look at this ECG. I have only one question to you. Is this patient having left ventricular hypertrophy? How will I recognize that? By looking at S in V1 plus R in V5 or V6. Now let me calculate the amplitude of S in V1. What is the amplitude of S in V1? It appears to have 1, 2, 3 large boxes and a little more than 3. It is 3.5 large boxes. 3 large boxes is 15 plus another half. Let me take it as 3. So it is around 18 here. 18 small boxes. S is equal to 18 or 1.8 millivolts. and then I have to see the R in V5 or V6. I can clearly see it in V5, right? So I will look at V5. What is the voltage here? 1, 2, 3, little more than 3, slightly more than 3. Let me count it as another 2. So it is around 17 here, right? Around 17 here. So 18 plus 17, 35. So if it is 35 or more, I can consider the possibility of left ventricular hypertrophy here on this ECG according to Sokolov-Lyon criteria, right? Now let us go through one more ECG. What about this ECG? Do we have LVH here? When I look at it, what is the voltage of S in V1? It appears to be, we are looking at this. This is the S in V1, I'm sorry. This is the S in V1. So it is less than 5 small squares, right? Let us count it as 4. And then R in V5 or V6. V5 I can clearly see. How much is it? One large box, or 1.5, another 1.5. So roughly 2 large boxes, that is 10. So S in V1 and R in V5 or V6. I calculated in V5, that is 10. So sum is 14. That means this patient does not have left ventricular hypertrophy. Okay. Now what about this ECG? Does it have left ventricular hypertrophy? S in V1 is clearly visible. This is the S in V1. If I mark it, if you are able to see this, this is S in V1. So this is 1, 1.5. So this is around 8, right? S in V1 is equal to 8 on this ECG. And then I have to look at R in V5 or V6. Let me see R in V5. How much is it? It is also around 7, not fully 2 large box. Let me count it as 8 otherwise. So if I say R in V5 is 8, so that total becomes 16. That means this patient also does not have left ventricular hypertrophy, right? Now let me take you through the next ECG. Let us look at this. The S in V1 extends all the way till here, right? So how much is it? 1, 2, 3, 4, 5, 6, or little more than 6. Even if I count it as 6 large boxes, that means S in V1 is equal to 30. And what about R in V5 or V6? V5, I'm not even able to see where is it ending, but I can see in V6 clearly. So let me apply it in V6. So when I see V6, how much is it? 1, 2, 3. I can say roughly 4, right? So here R in V5 is equal to 20. So what is the total? 50. Is it more than 30? Yes. So according to Sokolov-Lyon criteria, I do have left ventricular hypertrophy here. And many a times left ventricular hypertrophy, if there is left ventricular strain, there may be inversion of T waves like you see here. So that means this is the classical case of left ventricular hypertrophy. Clear? Now the only thing that Umar, the P and T wave will also be decreased, but what is the usual amplitude of P wave, T waves? It is very minimal. So the decrease is subtle for us to appreciate. But QRS complex amplitudes are very high. The decrease can be easily perceptible. Okay. Now the last thing. Can the high QRS amplitude help me to diagnose the right ventricular hypertrophy? Yes, we can also diagnose the right ventricular hypertrophy on the ECG. RVH, how will I diagnose? So remember one thing, we have already learned how to determine the axis. So many patients with right ventricular hypertrophy, the axis will be deviated to right because right ventricle is hypertrophied, more impulse is going in that direction. Okay. But in terms of voltage criteria, what we look at, I've told you that the most prominent wave in normal ECG in V1 is S. But in right ventricular hypertrophy, it tends to become R. So for diagnosis of right ventricular hypertrophy, we look at the ratio of R by S in V1 and V6. V1 and V6. In normal conditions, if I look at the ratio of R by S in V1, what will I get? Forget RBH in normal condition. In normal condition, the most prominent wave in V1 is S, right? Yes, S is more, R is less. So R by S ratio will be less than 1 in normal condition. And if I do that for same normal condition in V5 or V6, V5 or V6, R is the prominent wave, S is barely visible, S is very small. So here if I look at R by S ratio, R will be more than S, so it will be bigger than 1. But when I have right ventricular hypertrophy, the ratio gets reversed. That's my best clue to recognize right ventricular hypertrophy. So R by S in V1 more than 1 and in V6 less than 1 is suggestive of right ventricular hypertrophy. So let's go through an ECG to determine if this patient has got RVH. Does this patient have RVH? If I look at R by S in V1, what do I notice here? This is the amplitude of R and this is the amplitude of S. So here R is smaller than S. So R by S will be less than 1. So is it consistent with the diagnosis of RVH? No, this is more consistent with the diagnosis of normalcy, not RVH. Okay. But if I look at this ECG again, R by S ratio in V1, what will I get? R is barely visible. R is almost equal to 0, right? And V1 shows clearly deep S. So if I look at R by S ratio, it will clearly be less than 1. It will be 0. R is actually 0. But now let us look at this ECG. When I look at V1, what do I notice? V1 shows a prominent R wave, right? This is the amplitude of R. And look at the S. S is very small. So here if I look at R by S ratio, how much it will turn to be? Amplitude of R wave is almost like almost 2 large boxes. S wave is not even 1 large box. So R by S ratio here will be more than 1. And if I look at V5 or V6, what do I notice? Normally V5 or V6, R by S ratio, R will be dominant, S will be less predominant, so it will be less than 1. But here it is reverse. Like look at V6. This is the amplitude of R wave, 1 large square, and amplitude of the S wave is 1.5 large square. So if I look at R by S ratio here, what it will turn out to be? So in V5, the R by S will be less than 1. So that makes it a case of right ventricular hypertrophy, right? So to summarize, QRS complexes, we can use them to recognize whether there are decrease in amplitude, increase in amplitude, and whether they are prolonged or not. Prolonged can be seen in RBBB, LBBB, drugs, ventricular arrhythmias, and WPW syndrome, right? Amplitude, low amplitude can be seen, which is defined as less than 1 millivolt in chest leads or less than half millivolts in limb leads, typically seen in hypothyroidism and effusion or cardiac tamponade. High voltage we use for diagnosis of LVH and RVH. The criteria for LVH is Sokolov-Lyon. S in V1 plus R in V5 or V6 more than or equal to 35 is LVH. And for RVH, we look at the R by S ratio in V1 and V6. Normally in V1 it should be less than 1 and V6 it should be more than 1. But if it is flipped, then we will consider it as right ventricular hypertrophy. So that's it for me from me today, guys. We have taken a brief idea about the QRS. I want you to exercise detection of RVH and LVH on the ECGs. You will get plenty of internet examples. Go through that. And in the next session, we will talk about the most important part of ECG, which is ST segment, ST elevation MI, and how to recognize other abnormalities of the ST segment. So with that, I'm signing off today. I'll see you in the next class. Till then, have a good time.